Bismillahirrahmanirrahim. Chronic pulmonary aspergillosis, also known as chronic necrotizing aspergillosis, chronic pulmonary aspergillosis, or subacute invasive pulmonary aspergillosis. Definition: poorly defined, but it's clear that a low-grade chronic invasion of aspergillus into the airway walls and the surrounding lung can occur. In the original descriptions, some cause of mild immunoincompetence was present, e.g., diabetes, steroid therapy, chronic lung disease, poor nutrition. Aspergilloma. The term aspergilloma is used to describe a ball of fungal hyphae within a cavity in the lung. It is assumed that this is colonization of a prior cavity, that's to say saprophytic infection, rather than arrested invasion. Aspergillomas can occur in other organs, including the pleural space. Aspergillomas are usually asymptomatic and useless part and unless part of chronic pulmonary aspergillosis and therefore only require treatment in the context of chronic pulmonary aspergillosis. Pathogenesis. It is assumed that this form of aspergillosis results from lowered immunity in those with a tendency to make T helper cell eosinophilic responses to antigens. There is infiltration of hyphae into lung tissue, ranging from minor patchy consolidation to multiple cavities. There is little, if any, angioinvasion. It is assumed that the fungal digestive proteases gradually do the damage rather than the host's immunological response. Clinical features: suspect semi invasive aspergillosis when middle aged, reason for mild immunosuppression such as diabetes, alcoholism, and steroid usage, including inhaled, a pre existing chronic lung disease, indolent presentation with fever, malaise, and weight loss, associated with cough, shortness of breath, chest discomfort, and occasional hemoptysis, patchy indolent chest x ray changes. Investigations: sputum samples may allow isolation of the hyphae, varied radiological appearance, including lung cavities with or without an aspergilloma, infiltrates nodules, and various degrees of lung or pleural fibrosis. Different forms are recognized with subacute or semi, i.e., some immune suppressions, more rapid course, nodules and consolidation, predominant, predominant on CT. The chronic cavitary pulmonary aspergillosis constitutional symptoms: thick walled cavities, single or multiple with or without aspergilloma, and chronic fibrosing pulmonary aspergillosis characterized by progressive fibrosis. Diagnostic test is immunoglobulin G to aspergillus with associated evidence of aspergillus in the sputum, culture or polymerase chain reaction PCR. The management: on the assumption that mild immune suppression is the dominant cause, steroids are not usually recommended for fear of further immune suppression. There is, in contrast to ABPA, where The damage is due to host's immune defense mechanisms. On treatment with itraconazole, voriconazole is usually appropriate, but IV therapy is required for severely ill patients. The alternative treatment options are as for invasive aspergillosis. Hemoptysis. Tranexamic acid must be taken during clot formation as binds to fibrin to prevent action of endogenous fibrinolysis. Treat associated bacterial infections. Consider itraconazole, voriconazole. Bronchial arteriograms should reveal a leash of vessels supplying part of the cavity wall that can be embolized even if not actively bleeding. Short term success rate of embolization is good, long term less good. Surgery can be difficult as myocytomas may be stuck to the chest wall. Problems of seeding the pleural space are seen less often than in the past, probably due to better antifungal agents. A few case reports exist of success reduction of hemoptysis with radiotherapy. Older approaches involving intracavity injections of amphotericin are rarely used now, although a recent case series of 40 patients seemed promising.